All right, so good evening once more, and I want to officially welcome all of you to this last series of enteral nutrition for oncology patients. It is my pleasure and honor to be able to impact skills on this area of enteral nutrition and cancer patients. But interestingly, this topic does not only cover cancer patients alone, but it is also looking at other patients, like any patient who requires enteral nutrition. So I hope the knowledge we are gaining from this point is not only applicable to cancer patients alone, but to all the patients who require enteral nutrition so that we can serve our patients better. Again, another reason why we are doing this series is for us to also go back to our facilities and be able to host CME for our other colleagues, because for us to achieve a better outcome, we need to have a multidisciplinary approach. So I hope that after this 2-day series, you'll be able also to have a meeting with your team and maybe share the latest and even do some practicals, because again, this information just need practical for it to be able to sink in. So just to give you a background of what we learned yesterday. Yesterday, we were able to look at several areas. We were able to look at the introduction definition of enteral feeding, specifically to cancer patients, but again, across board. And then also indications of enteral feeding. We were able to look at contraindications. We looked at the monitoring aspect of enteral nutrition. We looked at different types of tubes, tube feeding, the routes of tube feeding. We were glad also to look at the monitoring. What do we need to monitor when a patient is on enteral feeds? Which parameters and indicators do we need to monitor? And how frequent should we do that? And then, of course, we were able also to tackle a little bit of some of the administration, both the bolus and also the continuous. So I hope that really was able to give you an highlight. So as I promised yesterday, today we are going to look at complications of enteral feeding in details and how to manage them. And then also we'll be able to get time to look at a case study that I've prepared for you. And lastly, I promise that I'll share with you also the different formulation for enteral feeding so that you'll be able to choose from them for your patients. So without much further ado, let's just go straight to the presentation. So we are starting with complications of enteral feeding, enteral nutrition in specifically. So just to give you a background, that enteral nutrition is quite safe. It is safe. It is an effective, generally well-tolerated approach to nutritional therapy in cancer patients with a normally functional gastrointestinal tract. So that is something that we need to note, that enteral feeding is really safe. Another thing, compared to parenteral feeding, is quite effective, and many a times it's generally well tolerated. I can assure you, and even some of my colleagues who have worked here can testify that it is easy to administer enteral feed than parenteral, considering the complexity of parenteral feeding and of course the expenses and what really is required for parenteral feeding to be effective compared to enteral feeding. So it is easy to feed a patient via gastrointestinal tract compared to the general circulation. So it is quite an effective method. However, there is a relatively opacity of evidence regarding the frequency of adverse effects due to enteral nutrition, but it is suggested that most complications are as a result of application errors. This is very key thing to note. Let me just bold this so that it hit hard. So literally, we don't have much studies on the adverse effects of enteral nutrition. But the suggestion is that most complications that patients experience, either they come from application errors. So application errors here means that they come from maybe inserting tube wrongly, or maybe giving feeds the wrong way. Like yesterday, we learned that ideally bolus feeds should run. We should start with 30 minutes per minute, 30 meals per minute, for extended period. But you find many a times when we are giving bolus in most of our facility, we push it as we pushing the medication. And that we saw yesterday is has a serious impact on causing diarrhea and even malabsorption. So those application errors are the ones that are known to cause uh, enteral nutrition challenges. So if you are able to get it right, then you'll not be able to have any challenge. Request. So, in terms of studies, there are several studies that have been done just to look at the enteral feeding in terms of complications. And today we'll be able to complications in details so that we'll be able to help our patients when they come to our facility. So the limited evidence that exists indicate that the most common complications are aspiration, number one, diarrhea, metabolic, and mechanical complications, which are also known as tube complications. So many a times, if you have a patient who is on enteral nutrition, the complication that you most of the time will experience, they'll complain from aspiration. Either the feeds are coming back into the lungs, diarrhea, because either this can be because of intolerance, or if in case where we are not able to administer the feeds correctly, they experience diarrhea. Also, we have what we call metabolic and mechanical complications. I'll be able to tackle all this today so that you're able to get the information. So, statistically, or in terms of frequency, complications for enteral nutrition ranges from different, as I've stated. So there's one that from the problem of compliance. Compliance basically means complying to the recommended, uh, uh, guidelines. Usually, is one of the has been picked to be also at around 10 to 40% of cases. Quite, you find that being on the higher side, that mostly 10 to 40% of cases range from compliance. Then we also have what we call tube malposition or displacement. Up to 50% of cases have been reported. And then we have nausea and vomiting, 10 to 15%. Diarrhea, 25 to 50% of cases. Infections is quite rare, though you will see how that can happen. Severe metabolic complications, they're still quite ongoing studies about that. Then aspiration is also, we still have some questions pertaining how that is happening. So you find that the more common complications that these patients experience are compliance, tube malposition or displacement. They experience nausea and vomiting, diarrhea, infections, which is quite uncommon, but again, it's also something that the patients experience. Then moving on, let's start with diarrhea, quite a common one, common complication of enteral nutrition. I hope we are following. If you are following, kindly let me know in the chat box so that we really catch up. So diarrhea is fairly common gastrointestinal complication of enteral feed. So you'll find many patients who are on enteral feeding. The major complaint that usually come, the commonest one is usually diarrhea. And there is a wide range for the prevalence of diarrhea in the literature. Of course, several studies have been done on that, which is most explained by different definitions used. So compared to other types of diarrhea, for enteral feeding, the definitions have always been different. For instance, if you are having diarrhea due to maybe cholera outbreak or anything, the definition will be different from the one that we see for enteral feeds. So diarrhea is one of the commonest complication of enteral feeding, and we look into it in details. So, for example, in ICU, the occurrence of diarrhea has been reported in around 15 to 18% of cancer patients receiving enteral nutrition, compared to 6% in those not receiving enteral nutrition. And this does not only apply only to cancer patients, but across board, that the occurrence of diarrhea if for instance you have 100 patients admitted and they are on enteral feeds, you anticipate that maybe 15 to 18 patients might have diarrhea complication compared to 6% in those not receiving. Of course, the exact mechanism is unknown, but it is probable related to alterations of intestinal transit or of the intestinal microbiota. So, the cause of diarrhea here could be due to the changes in the intestinal microbiota. For instance, we are interfering with the normal flora of the GIT, or we can have the challenges of transit. And transit, we explained yesterday. For instance, delivering. Uh, if we are delivering, for example, bolus enteral nutrition by pushing rather than having it to flow through gravity, then definitely will affect the intestinal transit time. So those are the main issues that also are linked to have to cause diarrhea. I mean diarrhea for that. Of course, other reasons include bolus administration or high feed delivery rate, bacterial contamination, or inappropriate temperature of the formula diet. And you remember yesterday we were able to get even some confessions that many a times, if you are working in the hospital setup, you find many patients who are on enteral feeds, they are rarely fed. Sometimes they are forgotten. You find the food porter or the what we call patient attendants will bring food and put it by bedside, and sometimes nurses will not even remember to feed that patient, and even the dietitian or nutritionist in the ward might be overwhelmed with so much work that they forget that the food was brought in. So by the time this patient, by the time the food is by the time we recall it, already the food is in low temperature. Sometimes they dispose them off. So this is one of the issues that this patient experience. So infection is common because the food again is given in low temperature. Of course, there's limited evidence that low serum albumin, that is less than 25 grams per liter, can cause diarrhea because of malabsorption as a consequence of intestinal wall edema. So we have few evidences to support that if a patient has low albumin, that they can have diarrhea. If this you compare with intestinal wall edema, which is the commonest cause of diarrhea, you find that intestinal wall edema is the major cause of diarrhea for patients who are undergoing enteral nutrition. So I looked out for reasons for diarrhea during enteral nutrition. What really causes diarrhea for this patient? And one of them is what we call bolus application. It's the commonest one, as we looked at it yesterday. If you are feeding the patient via bolus, they are easy to, especially if you are feeding them without considering the guidelines of doing 30 ml per minute, then they are easy victims of having diarrhea. And of course, we have high delivery rate. You remember yesterday we had quite a discussion that if we are doing continuous feed, this can even go to 20 up to 20 hours, and there is a amount that should run within an hour. So if we are doing, let's say, for example, we are doing a 5 ml bag feed that is supposed to go for maybe 5 hours, but we run this bag for 1 hour, then that patient definitely will have issues with diarrhea. And of course, we have high osmolarity is one of the issues that can cause diarrhea if the feed product has a higher osmolarity. Bacterial contamination of the formula diet. This is also very common. And I know also some situations in facilities, people lack enteral feed, so they usually give kitchen blended foods, which are usually not so recommended because of the hygiene standard and inadequacy in the nutrients. Then if your formula diet is too cold, that can also lead to diarrhea for these patients. Gastrointestinal infections like bacterial infection can cause that. Then, of course, we have malabsorption. So malabsorption can occur due to affecting the normal flora of the GIT. It can also occur when the patient is intolerant to, let's say, for example, milk-based product, or this can also occur when the patient are on antibiotic which affect the GIT. So all that can cause malabsorption. Again, for patients who maybe have lactose intolerance and gluten intolerance, they may experience malabsorption. So these are some of the reasons why patients on enteral feeds experience diarrhea, among other reasons. Now, you are feeding a patient on enteral feeds, and then of course you notice that this patient is having diarrhea. Many a times, what happens is that the doctors will tell you that we need to stop the feeds, but the standard does not allow us to stop feeding. If patient is experiencing diarrhea, and I'll be able to take you through that, how that really happens. Marisha, I'll be able to answer you as we later on, as we continue on osmolarity and diarrhea. So this flowchart is able to guide you to manage a patient well when they're experiencing diarrhea. And, I encourage you, if you can have this flowchart also, to you can print them out and you can use them even in your facility. This can help you very much to support those patients who have who are experiencing diarrhea and they are on enteral feeds. So let's go through this very fast. So we have clinically significant diarrhea, so meaning that you can see that this patient is having diarrhea. If there is a drug-related diarrhea, so if it is yes, stop the drug and continue enteral nutrition. So many a times patients become victims of starvation. When they experience diarrhea, you find doctors or maybe other care providers stopping feeds than investigating could it be diarrhea secondary to a certain drug that this patient is taking. So it is important for us to do what? To investigate and look at the treatment sheet. Could there be any antibiotic that this patient is on that is affecting them, especially the oral drugs? So if it is no, if there is no drug related, then you go further and say, is patient on antibiotics? That's another question that you need to ask. So you need to go to treatment sheet and check. If yes, test stool for Clostridium difficile toxins and continue enteral nutrition. So if the patient is on antibiotics, then you need to test stool for Clostridium difficile, which is quite common to cause diarrhea for patients who are on antibiotic. I hope we are following. Are we following the flowchart? Are we together, team? Is this making sense?
Yes.
Yes, we are.
Yeah, sure. So yeah, so you need to take the stool and take it for test, specifically for Clostridium difficile. If the patient is not on any antibiotic, check the feed. Could it be the storage? Could temperature and line of administration be a challenge? Remember yesterday we said that for enteral feeds, the temperature should be around 20 to 20, is it 20 to 24 degrees, if I'm not wrong, in terms of temperature. So for example, if the feeds have just come from the fridge and they're still cold, just know that that patient might experience diarrhea. So these are the information that you need to investigate. So check the feed. So you check the storage, if it was well stored, check the temperature and line of administration. So could it be that the line of administration is contaminated? If it is nasogastric tube, is there any signs of contamination? If the diarrhea has resolved after doing all this, then if yes, continue current feed formula. So if the diarrhea has resolved, you need to continue current formula. If no, then bolus administration stroke high delivery rate, you need to ask yourself, could it be the diarrhea is because of the bolus administration, or the feeds that are going continuously are being given at a higher rate? Okay, so it is quite that is another thing that you need to check, that if the feeds are being given at a higher rate, then that is a concern. So if you check bolus administration stroke high, then you need to change the diet formula, osmolarity, and fiber. All right, so I'll explain that. Allow me to explain osmolarity when we'll be looking at enteral nutrition formulas, and we'll be able to discuss that in details. So if the issue is not bolus administration, then now you can change the formula. But you find many a times we arrive here, the moment the patient has started diarrhea, we usually come to change the formula. We don't really go through this flowchart. So this flowchart is easy to guide you. Before you make a decision of changing the formula, just know that there could be any other factors which you haven't addressed. So in a situation where the patient, for example, was on bolus administration, then you need to switch to continuous administration, then reduce delivery rate until diarrhea resolves. So it is very important for us to do that. Then increase gradually to target flow rate. So if diarrhea was being caused by bolus, then you need to switch to continuous administration and then reduce the rate until you achieve the better gradual target flow. So I hope this will be able to help you practically work up those patients who are on enteral feeds and they are experiencing diarrhea. It is very important that you do this flow chart. This will able to guide you so well. So just to summarize what that flow chart means. So the flow up for diarrhea occurring during enteral nutrition include the following issues. So one of them is that you'll find that when bolus application has initially been performed, switch to continuous application using an electronic pump system. So you can either go electronic pump system. Nowadays we have what we call gravity sets. So because electronic pump system is quite expensive and some facilities do not have them, but we have the gravity set. So gravity set is the ideal one to use for such patients. I'll be able to share pictures so you can see them out. Continuous application of enteral nutrition is generally better tolerated than bolus application, even if the latter appears to be more physiologic. So even if the 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 latter, that is the bolus being good, but continuous is the best because it is well tolerated. Then the second thing that you need to do, decrease the delivery rate. Sometimes it is effective to decrease the delivery rate only for 1 or 2 ways, then increase the rate to the initial level. So I wish I could get time to help you calculate how to calculate enteral feeds, but allow me to prepare a slide, then I'll be able to share in the group because I know time might not allow us for me to have that. So I'll take you step by step how to calculate enteral fees and even how to calculate the rate of administration. I think that is much important for us. So the maximum tolerated delivery rate does usually not exceed 120 ml per hour, which is equivalent to the physiologic flux into the duodenum. So the maximum flow rate should not exceed 120 ml per hour. So if you need to calculate this per minute, you divide by 60 and you'll find that you'll have around, is it how many meals per minute? 2 meals, huh? Yeah.
Two.
Yeah, 2. So that means if you also need to do the drop rates, you can do that very easy. Then avoid bacterial contamination of the formula diet. Change the drip line daily. So if you're doing the drip line, the gravity set I've explained, you can change them daily. Review the manufacturer's guideline for the use of the formula. When the open systems are used, the formula diet should be delivered within 6 to 10 hours. Feed should not be made up in advance. This is also another issue. I know there's a victim in this class. Allow me just to mention, I know Daisy, do you usually prepare feeds in advance? Are you a victim? Daisy, you are in this class and I know you can hear me. Okay. So don't prepare feeds in advance. Kindly prepare just when the patient is ready to be given. Because again, preparing feeds, especially I know right now we have challenges with enteral feeds in facilities. So you find the patients will be mostly be on kitchen feeds, and they are usually prepared early in advance, and that is a known cause of diarrhea. Then, of course, review patient's prescription regarding diarrhea-inducing drugs. By the way, nutritionists in this forum, do you usually check the treatment sheet? I know later on we'll be having another series on drug-nutrient interaction. Japheth, my brother, how are you? I hope you can hear me. Do you review treatment sheets of your patients?
I can hear you, Ken.
Yes. Do you
Yes, we
usually
do.
review the treatment sheet?
Yes, we do, but most of the time you just end up wondering what is here.
Okay. Okay. Bernice has said yes. So you just wonder what is it? Oh my god. So I think we need to have more series on drug nutrient interaction so that we can be able to really uh, we can be able to really get to look at those drugs versus their nutrients, because if we fail to review treatment sheet, my friends, that's why sometimes if diarrhea occurs, and a doctor say that stop feeding that patient, yet they are the ones causing the diarrhea. So make sure that you do review treatment sheet, and if you don't have anything to support, you can inquire. Then we can ever assist. We are here to usually consult and support each other. So treatment sheet is important for us to see. As you've seen in the flow chart, medications could be the cause of diarrhea. Then, of course, exclude gastrointestinal infection, that is stool culture, including screening for Clostridium difficile toxins. So that is very important. If malabsorption is suspected, change to low molecular diets. If diarrhea persists, change to a soluble fiber containing enteral nutrition. So we'll be able to look at those formulations, so don't worry. I know in the market we usually have brand names, but for me today I'll just share with you how those formulations looks like. So you can go to the booklets of the provider, manufacturer, so you get the brand names. So for diarrhea in enteral nutrition, the first thing you need to do, keynote information, the ideal temperature of the formula should be at 20 to 25 degrees. I know you might not be able to measure this temperature, but room temperature is usually advised. So make sure that you get them off the refrigerator or the freezer earlier. Enteral nutrition-related diarrhea is often associated with concomitant administration of medications that affect the intestinal microbiota, especially antibiotic, but also proton pump inhibitors. What are some of the examples of proton pump inhibitors? Anybody? Examples?
Omeprazole or
Omeprazole?
esomeprazole.
Yes.
Yeah.
So that one is usually the common victim, omeprazole and esomeprazole. So they are the commonest ones that you need to check. So you see now those are also things that you need to really be checking rather than thinking that indeed it is the your food. Don't be a victim of people's problem, please. This is why information is important. Don't fall a victim. Don't be victimized. Yet the problem is being caused by somebody else. Then always they look at the nutrition as a loophole. There could be more factors, so check on that too. Then, of course, the latter often contains, so that is the latter, that is the microbiotic, contains sorbitol, and an absorbable sugar that causes diarrhea when administered at a high dose as a vehicle. That is proton pump inhibitors. And then, of course, before intolerance of enteral nutrition is considered, one must also exclude gastrointestinal infections and disturbances of nutrient absorption, e.g., due to milk protein, allergy, exocrine pancreatic insufficiency, or lactose intolerance. So you need also to ask the patient, could it be a lactose intolerance issue that is causing them to that? Then enteral nutrition should not be interrupted for diarrhea, but should be continued while the etiology is being investigated. By the way, let me just underline this in bold. Please don't stop enteral nutrition because of diarrhea. Do the investigation, follow the flow chart. Because the moment you stop enteral nutrition, that means that patient is going to starve. The patient is going to starve. They are going into refeeding syndrome. You don't want to get into that. We'll discuss refeeding syndrome later on in this series. But I'm urging you, if you are already started this patient on enteral nutrition, please don't stop because of issues of diarrhea. Continue as you investigate. So the flow chart should be in your notice board. The flow chart should be on your bedside so that you keep reminding yourself. Fine. Having looked at diarrhea, let's look at aspiration also as another cause of enteral nutrition complications. So abnormal entry of fluids into the lower airways may result in severe pulmonary sequelae, which depend upon the volume and the composition of inhaled fluids and host defenses. So if the tube was wrongly inputted, then you know that you are going to experience issue of aspiration. Or sometimes it can come also because of the positioning of a patient during feeding. You remember yesterday we said at what degrees should the patient be when we are feeding them, especially those on nasogastric tube? Which degrees, if you remember? Those who were in class yesterday? Those who were able also to have the recording?
Ilikuwa 30 ama?
Yeah, 30 degrees, yeah, 30 to around 45 degrees. So it is important that you know that, because sometimes we might be feeding the patient, yet the bed is wrongly elevated, and that indeed can be a problem. So be sure to master that one, so that you are able to know exactly what we are looking into. So that the elevation is very, very important, so that the patient do not aspirate. So aspiration of gastric and small bowel contents into the respiratory is the most critical complication of enteral nutrition and may finally result in pneumonia or sepsis. So aspiration of very small volumes of fluids, that is microaspiration, occurs during sleep in up to 50% of normal population, in whom it is not associated with untoward clinical outward clinical outcome. So yes, sometimes you find when a patient is sleeping, they might experience aspiration, but just their small amount. Then clinically significant pulmonary aspiration is more common in critically ill patients, and when the patients are fed via nasogastric tube rather than PEG tube. So it is very rare to find uh, patient experiencing aspiration when we have PEG tube, but now mostly it occurs in patients who have nasogastric tube. So abnormal entry of fluids into the lower airways may result in severe, that one I think we've discussed. Aspiration of gastric and small bowel content into respiratory is the most critical. I think that one we've already covered. It is yeah. So it is caused by combination of factors which include supine position, favoring gravitational backflow. So if a patient is sleeping in a way, something I think they are sleeping on their which side? They're sleeping on their abdomen, or they're sleeping flat. That can cause the backflow. Impaired lower esophageal sphincter relaxation can also cause uh, aspiration. Then of infrequent esophageal contractions and the presence of tube across the esophageal gastric junction can also cause aspiration. So those are some of the things that you can look at. Let's look at some of the strategies to reduce aspiration. One, they include backrest elevation, as we learned that we need to have at least 30 degrees. Post-pyloric feeding and administration of prokinetics. So this really help. Prokinetics, remember we learned yesterday, they fasten the flow of feeds very fast. The rationale of these measures lies in the assumption that reflux of gastric content favors aspiration and pneumonia. So when there is a reflux, you can have aspiration and pneumonia. Then post-pyloric feedings should not be routinely performed, but it should be considered on a case-by-case basis. Then similar consideration apply to the administration of prokinetic agents like metoprolol and erythromycin. Remember, we learned that yesterday. So that one also can be able to can cause issues of aspiration. So you really need to be sure that which is which. Then moving on, also we have the aspect of in order to prevent aspiration in high-risk patients, prefer a semi-recumbent position that is 30 to 45 degrees. We learned that yesterday. Prefer nasojejunal instead of nasogastric tube. So if the tube is going up to the jejunum, then it means that you are going to have semi-elemental formulas which already have the feeds will just go through the jejunum and they might not be able to come back. Then in the presence of clinical changes, measure gastric residue volume, adjust the delivery rate, prolong delivery period. So in case where there's clinical changes that occurs due to aspiration, then you need to check the gastric residue, meaning before you feed the patient, kindly withdraw and see how much of residue are still in the stomach before you continue with another one, so that you can slow the delivery rate to allow the feeds that are already on the stomach to go down. Nausea and vomiting is another big thing that causes the aspect of one of the complications. So nausea and vomiting is another thing we are going to discuss and see how we can be able to tackle it. Let me see the questions coming up. Yeah. Sapping is sleeping on the back. Thank you. Yeah. So nausea and vomiting. So how do we nausea occurs in 15 to 20% of patients receiving enteral nutrition, but many of them suffer from diseases which are themselves associated with high risk of nausea and vomiting. E.g., we have cancer of the upper gastrointestinal tract, like maybe esophageal cancer, are quite common. Furthermore, antineoplastic therapy, radiation, and chemotherapy is a strong trigger for nausea and vomiting, and consequently requires antiemetic therapy before enteral is initiated. So if you are working in the oncology unit, you find that many patients who are undergoing chemotherapy or even radiation therapy, they are put on a drug called ondansetron. So ondansetron is antiemetics. It helps those patients not to vomit. All the patients, anytime they are put on, they are going to be on chemotherapy, they are put on ondansetron. So nausea and vomiting, reasons for impaired gastric empty during enteral nutrition. So we have pre-existing disease. So it could be the patient could be having diabetes, or for example, the patient could be having a condition called vagotomy. I'll be able to explain that in a moment. Then, of course, we have what we call systemic scleroderma. It's also very common to cause nausea and vomiting. So we also have issues to do with the myopathies. If they are experiencing myopathies, that can also be able to cause the issues of nausea. Then, of course, acute disease related could be pain and stress, pancreatitis, spinal cord injury, that can also cause that. Of course, vagotomy is just a surgical procedure that involves cutting or removal of part of the vagus nerve. And remember, vagus nerve is the one that is responsible for peristalsis. So the moment the vagus nerve have been interfered with, then you know that you are going to have challenges with peristalsis, the movement of it. So acute could be pancreatitis, spinal cord injury. Those are quite known to cause nausea and vomiting. Then, of course, we have extensive trauma, abdominal surgery, burn injuries, medication like opioids, anticoagulants, coagulants, all those are known to cause nausea and vomiting. So when patient is on enteral feeding and they are having nausea and vomiting, kindly be sure to investigate which could be the one of the things that cause that. And then, so moving on, so cancer patients with nausea might be so dominant that enteral becomes impossible and total parenteral nutrition must be considered. So for cancer patients, sometimes nausea and vomiting might be too much that even with intervention, it might not help. So such patients, kindly consider total parenteral nutrition for them. Do not delay that. Then delayed gastric empty is the most common cause of nausea related to tube feeding, and this may be aggravated by pain, ascites, that is fluid overload, immobilization if the patient is not able to move around, sedatives, antibiotics, all that may cause delayed gastric empty. So in ventilated patients, a high positive and expiratory pressure might induce vomiting with the risk of aspiration. So in some patients, abdominal distension and nausea might occur only transiently after initiating enteral nutrition. So you need to be aware of all this information. All right, so for nausea and vomiting, of course, you can't do much. What you can just do is try to allow the patient to relax, provide them with antiemetics that will be able to assist them. And sometimes you might be able to stop feeds for a moment, but if it is severe, don't hesitate to start parenteral nutrition for those patients. Let's look at constipation as another complication of enteral nutrition. So constipation is less common than diarrhea during enteral nutrition and more prevalent in patients requiring long-term enteral nutrition. So for patients who are on long-term enteral nutrition, they might experience constipation. Decreased fluid intake, high energy and energy-dense formula, and lack of dietary fiber are possible reasons for constipation associated with enteral nutrition. So for instance, if the patient was being fed on fiber-free diet and they are experiencing constipation, then those patients, you really need to add more fiber into their diet. Then, of course, if the patients are immobile, especially the critically ill patients, and decreased bowel motility as a result of sedatives or opioids may contribute to constipation. The primary goal of constipation management is prevention. So we need to find out how to prevent. For instance, cancer patients experience constipation because they are on opioids, and example of opioids is which is this drug now?
Morphine.
Morphine. Thank you. Yeah, so morphine is well known to cause constipation. So especially when they are doing oral morphine, it is quite common to cause constipation. Just give me 1 minute. I sort something here.
Hurry.
All right, salimia baby hapo. Okay, so let's proceed. I think now I'm okay. So morphine is one of the medications for cancer patients that is known to have to cause them to have that. How is fiber introduced in blended food? Perfect. Can aspiration from enteral feed cause sudden death? Good. Today I'm so happy with the questions I'm seeing. So it is good to really post them so that we answer them. So special caution should be taken in patients on enteral nutrition with impaired peristalsis, that is reduced flow of feeds. Those on vasopressors because they are more prone to develop what you call fiber bezoars. This complication, although rare, can be associated with severe sequelae and should be recognized and treated promptly. So there's a condition we call fiber bezoars, which is quite common for patients who are on vasopressors. So you really need to do the investigation. So how do we sort out patients who have challenges with constipation secondary to enteral feeds? One, review patients' enteral prescription. So if, for instance, if they were on low fiber feeds, then you can introduce that. Number two, increase fluid intake, reduce density of formula, or switch to fiber containing formula if for some reason they have not been the first line choice. So that should be happen. Exclude bowel obstruction. So this you can do through auscultation. So when you have the stethoscope, by the way, do we know how to use stethoscopes to check bowel sounds? Anybody
Yeah.
on the who
Mm,
has? We can do that. You can do. You can auscultate the abdomen.
yes, comfortably.
Great. Nice. So you make sure that you are able to really do the right one, so that you can hear the bowel sounds. It's important. This can also help you, especially for patients who have just come out of theater and you need to start feeding and you are waiting to have a bowel sound. You make sure that you can auscultate. And then, of course, X-ray for abdomen can be done. It could be intestinal obstruction, so please don't just ignore the constipation patient is experiencing. So they can send them for X-ray just to confirm if it is not intestinal obstruction we are dealing with. So if these steps fail, consider stool softener like lactulose or bowel stimulants, so that if the patient is able to pass stool or flatulence, then you can be able to proceed with feeding. So that is the procedure for constipation. Great. Let's look to another complication called tube-related complications. Okay. So tube-related complication, the use of nasal tube should be limited to short-term enteral feeding, that is 4 to 6 weeks, in order to prevent necrosis or ulceration of the nasopharyngeal, esophageal, gastric, or duodenal mucosa. So if a patient is going to be on nasal tube for feeding, then please, we should restrict ourselves for that to be 4 to 6 weeks. So let's not, if it's going beyond that, then you definitely know there could be issues of necrosis, or they were going to have some wound on those passage areas. So these complications, however, become very rare after introduction of modern fine bore tubes. So despite this being a common complications, but nowadays the tubes that we are having in the market, they are quite okay to use. So they are quite fine tubes. So these ones might not be able to really cause more problem. They have been modified, but however, we still insist that 4 to 6 weeks should be the standard for short term enteral for nasogastric tubes, nasal tubes. Then when long-term enteral nutrition, that's more than 4 to 6 weeks, is anticipated, insertion of gastrostomy tube should be considered. This can help us to prevent tube-related complications. Of course, complication of gastrostomy tube placement may be minor or major and may develop immediately after tube placement or later. So that can occur. Most complications are minor and range from skin maceration due to leakage of the gastric content around the stomach to peristomal pain with frequency of 13 to 40%. So 13 to 40% cases is where we might experience complications of gastrostomy tube. Now, several studies have been done just to check tube-related complications, the major complications that we have. So aspiration could be one, which around 0.3 to 1% cases. Hemorrhage, that is bleeding, is 0 to 2.5 chances of having that. Peritonitis, 0.5 to 1.3%. Necrotizing fasciitis, quite rare case. Death, 0 to 2.1 chances or cases have been reported for death. What we call tumor implantation is quite rare. We learned yesterday that tumor might originate from the site where the tube has been placed. Then, of course, minor complications. So the first ones are the major complications that could occur due to tube challenges. So minor one, we have tube occlusion. I think this one we discussed it yesterday, the clogging of the tube. Is quite high, 25 to 35%. What we call peristomal infection, infection of the pericardium cavity, 5 to 30% cases. In adventent removal, that you find that the tube get out of itself, we have cases of 1.6 to 4.4 chances. And then, of course, we have stomal leakage, 1 to 2%, fistula struct, 0.3. What we call barred bumper, we discussed this yesterday, could be also 0.3 to 2.4, gastric ulcer, and ileus. So all these are the complications that can occur due to tube feeding. Now, after looking at all that, I want us to switch ourselves to a very, very interesting topic called refeeding syndrome for enteral nutrition. I hope this is going to be one of the best area to learn about them. Refeeding syndrome. You've had refeeding syndrome for parenteral feeds, enteral feeds. Here we have it. So it's called also known as tube feeding syndrome. So this is where hyper or smaller formula diet causes diarrhea and intestinal fluid losses, acidosis, and impairment of renal function. So refeeding syndrome is quite common. So this usually you find that the patient condition changes. Maybe if the patient has been starving for long and we start on a higher or smaller feeds, meaning the feeds which has a higher density or feeds which is high in calorie, then this is known to cause diarrhea, intestinal fluid losses, acidosis, and impairment of renal function. So overhydration and dehydration are usually accompanied by what we call hyponatremia, that is low sodium level, and hypernatremia, high sodium level, respectively. So if you are going to overhydrate the patient, give more fluids than it is recommended. That's why calculation is important, and I wish we could get time to do this, to calculate enteral feeds, but just allow it with me. If you're not able to do it for this series, even we can spare time next week, even for like 30 minutes, just to take through step-by-step calculation of enteral feeds. It's important for you to learn. So overhydration occurs frequently, particularly when patients are receiving concomitant intravenous fluids. So you find it is important that we calculate the fluid requirement of patients. Do anybody have an idea how to do that? The formula. Daisy, your microphone is on, so you have the pleasure of answering us. How do we calculate fluid intake? You've run away.
Hi, I can try.
Go ahead.
I normally use the first 10 kgs, you multiply by 100, the next 10 you multiply by 50, then the remaining you multiply by 20 if they're below 50 years, and then if they're above 50 you multiply by 15. the one we
Great,
use.
thank you. That's perfect. That's one of the formulas. There's another one also I'm looking for. Mhm. Mhm. Any other person with a different formula? So I know for bands is a different thing. Yes, go ahead. Mhm.
Okay, there's the one that we normally use. We calculate the total kilocalories. Then 1 kilocalories equals to 1 ml of the fluid.
Great. That's also a perfect one. That's also the easiest. So you just get the total kilocalorie your patients require, and then you project that the amount, the volume of the feeds that you're giving is also the fluid. The last one, we have 30 to 35 ml per kg can also be used to calculate the amount of feed the patient requires. But again, that one also for elderly, you need to also to be very cautious. Another important thing that we need to note is that this total fluid the patient requires includes even enteral feeds, parenteral feeds, and even the drugs and medication. Many a times we just calculate the fluids required and we assume that we don't factor in when, because sometimes you find patients being on normal saline just yet they are already also having enteral feeds, so you'll have fluid overload. So it is important to note that the parenteral feeds, like let's say we are doing dextrose and we are doing alternating with normal saline, they still cover the total fluid that this patient require. So for us to avoid overhydration. So as we can see that overhydration can cause challenges can cause refeeding syndrome. Then of course, concomitant comorbidity impacting on hydration state include renal and liver failure must be taken into account. So you need to do liver function test. You also need to do kidney function test just to see the performance. So metabolic complication is the tube feeding syndrome, which is potentially life-threatening condition determined by sudden shift in fluid and electrolytes when severely malnourished patients are given oral, enteral, or parenteral feeds. So tube feeding syndrome is also known as refeeding syndrome. It's quite common metabolic complication, and it is a life-threatening one. So it is important for us to really be cautious. So the main biochemical feature of refeeding syndrome is what we call hypophosphatemia, with its clinical consequences, which include cardiovascular and respiratory failure, seizures, rhabdomyolysis, and delirium. So many patients who have hypophosphatemia, if you do the phosphorus level, you find that it is low. They usually come with the issues of cardiac issues. Either heart rate becomes so high. We also have the issues to do with respiratory failure. It's quite common also for such patients. We have also the condition called rhabdomyolysis. It's just a muscle injury where the muscles break down. It's quite common because remember, phosphorus also is able to help us in muscle coordination. And delirium is the issues of mental issues, hallucination, they become confused. So those are quite common. That is the one thing that you can see. So often associated with hypokalemia and hypomagnesemia. So all this, if you do lab works, all this will be low. They know that your patient is in the refeeding syndrome. Then, of course, thiamine deficiency. We know thiamine is vitamin B6. Isn't it? Is it B6, if I'm not wrong? No, B6 is pyridoxine.
It's B1.
B1, thank you. Yeah,
It's B.
yeah,
B1.
exactly. Oh yeah, exactly. B1. So so thiamine deficiency, remember B1 and B6 are known for the issues of nerves. So thiamine deficiency and fluid retention, which also characterize the syndrome, ultimately can result in cardiac arrhythmias, congestive cardiac failure, and a condition known as Wernicke's encephalopathy. So there's a condition called Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome is more of alcohol withdrawal syndrome that most patients who are admitted have alcohol withdrawal syndrome. So how Wernicke encephalopathy works is that you are going to have if the alcohol, if the patient is a chronic alcohol intake person, and then you stop giving the alcohol part, then they start having confusion. So Wernicke encephalopathy is where they experience confusion, the delirium. So you find many patients who have alcohol withdrawal syndrome, they start seeing their own things, they feel like they're going to die. That's called Wernicke encephalopathy. But the condition itself is called Wernicke-Korsakoff syndrome. So it was just named after the scientist known as Wernicke-Korsakoff. But now the Wernicke encephalopathy is more of mental brain issues. So usually the signs of Wernicke-Korsakoff syndrome is so such patients are put on IV thiamine, the experience, and also pyridoxine of thyroid. Yeah, so Wernicke-Korsakoff is that. Then milder forms of refeeding syndrome are probably not so uncommon and may be identified by biochemical alterations of micronutrient status in the absence of clinical symptoms. So how do we identify patients who are at risk of refeeding syndrome? There was a question that was posted by a colleague. I don't know if she managed to join, but thank God, Bernice, you are here. The case study that our colleague has shared in the group, I think it is important that we note that that patient also was at a risk of going into refeeding syndrome, looking at the parameters that we were given. So now you have a patient who has just been admitted. How will I know that this patient of mine is going to be at risk of a refeeding syndrome? So you need to plan early. Number one, BMI less than 16 kg per meter square. That's one. Number two, and patient has one or more of the following. One, even if they have one, that's a risk of refeeding syndrome. Unintentional weight loss greater than 15% within the last 3 to 6 months. If they tell you that in the last 3 months they were weighing 50 kg, then you do that 15% of 50 kg. Just allow me to do that calculation quick, so that divide by 100 times 50. So if there were 50 in the last 3 months and then 50 minus 7.5, they come in with 42.5 kg, that they have lost almost 7.5 kg in the last 3 months. Just know that patient is at a risk of refeeding syndrome. Little or nutritional intake for more than 10 days. If they have not been feeding well for more than 10 days, refeeding syndrome is on the offing. Low levels of potassium, phosphate, or magnesium prior to feeding, be sure that that patient might be on refeeding syndrome. Or the patient has 2 or more of the following. BMI less than 18.5 kg per meter square, unintentional weight loss greater than 10% within the last 3 to 6 months, little or no nutritional status for the last more than 5 days, a history of alcohol abuse or of drugs including insulin, chemotherapy, antacids, or diuretics, that patient will be at a risk of refeeding syndrome. Do we have these patients in our care? Is it true?
Yes, it's very true.
Yeah, so it is important. Again, this is also another slide I would like you to have in your rooms, so that in your wards, so it can help you identify this patient, because many of our patients maybe die. We rarely think that nutrition can kill, but indeed it could be us are the ones killing the patients early, because if we are not able to investigate the refeeding syndrome early, then we give a high volume nutrient, that patient will definitely go into refeeding syndrome and they might lose their life. So refeeding syndrome findings. So these are the things that you need to look for. One is hypophosphatemia, low phosphorus level; hypokalemia, low potassium level; hypomagnesemia, these are signs; thiamine and other vitamin deficiency; fluid retention, all that are some of the signs and symptoms. Then, of course, they'll experience neuromuscular dysfunction, hypoventilation, lactic acidosis, cardiac arrhythmia, congestive heart failure. All that have are some of the signs and symptoms you need to look for. So this is how you need to check for refeeding syndrome. This is also another slide I would like you to have with yourself. How do we prevent refeeding syndrome? So these are the steps. Number one, introduce and advance feeding gradually. So this should be Introduce and advance feeding gradually over several days while closely monitoring vital functions, plasma electrolytes, that is phosphate, magnesium, calcium, potassium, and renal function, heart rate, and ventilator function. So you need to introduce feeds in small rates. Then correct electrolyte and fluid deficiencies before nutritional support. This is also very important. If you have a patient who is experiencing hypokalemia, you need to correct it earlier before you start nutritional support. Then, of course, we have nutritional support should be started with reduced amounts of energy, like you can do 25 to 50% of planned energy intake. So let me give you an example. If your total kilocalorie your patient requires 1,500, okay, per day in 24 hours, then you can give half of 50% of that. About 500 to 1,000 kcal per day or 10 to 15 kcal per day. You could see that you can start at a low volume intake. So be sure that you are able to know at what rate you need to start your feeding. So it is very, very important that you can start low. Usually we advocate 25 to 30 kcal per kg per day, but to avoid refeeding syndrome, please, this is going to help you. So this is particularly during the first week of refeeding, and should be increased by approximately 20% daily until determined goal is reached. Fluids and electrolytes should be infused separately. The average weekly weight gain, particularly in extremely undernourished patients, should not exceed 0.5 kg per week. Oh my goodness, this is also very important. Please don't push that patient to have more problem, please. So make sure that you go slow. Don't be overambitious in terms of weight gain, because if they gain the weight so fast, that will have a problem. Then potassium, phosphate, and magnesium should be supplemented based on their plasma levels, so after lab test. So also identify patients at risk. I've told you the patients at risk, nimekuonyesha slides. Start nutritional support with less than 50% of calculated energy. Monitor phosphorus, potassium, chloride. Yesterday, we learned about how to monitor these parameters and how frequently. Supplement vitamins B1, B6, B12, and electrolytes are mandatory. My goodness. Banis, these vitamins should be supplemented, a must for such patient.
Yeah, that's what I've seen.
Exactly. I know we usually
We have to do tests so that we can give.
Exactly. So here is where if you know that you might not have the IV of this, you can just do the multivitamin. Then, but be sure that you check the amounts that are there and the RDA, recommended dietary requirement for those patients. Good. So having done all that, the last session here, just a quick one. I could see time running. Allow me to go through this case study. Then later on, just within 2 minutes, I'll be able to share with you the nutritional formulation for enteral feeds. Then we call it a day. So we have a case study here. So we have a 72-year-old man who presents to the emergency room with a 4-week history of progressive dysphagia. I hope you'll be following the case. Up to that point, tuko sawa? So this is a patient who is 72-year-old, 4-week history of progressive dysphagia. He has a history of alcohol abuse and esophageal cancer treatment with combined radio, chemotherapy, and surgery. Up to that point, we are okay. Now, 2 weeks before presentation, he has started to reduce oral intake, and by 5 days prior to admission, he has completely stopped eating, but his symptoms continued to worsen. Okay. Then in the last few days, he has been intolerant even to liquids. His actual weight is 65 kg, a BMI of 21 kg per meter square. His usual weight, body weight, is 71 kg. Therefore, he intentionally lost 6 kg in the previous 4 weeks. Quite interesting case study. Now, he is admitted to the hospital. Urgent upper gastrointestinal endoscopy shows stenosis of esophageal lumen that can, however, be overcome by endoscopy. So we can be able to correct that dysphagia. So up to that point, is it okay? Have you understood that case? Have you followed it? I need response. Up to that point with that case study tuko sawa? Ama niwapatie time muabsorb? Oh, great. Whether you are quiet or not, I think it has synced in. Aye. Moving on to continuation. So the first question we are going to ask, is the patient malnourished? Let me hide the answers first and take you back. Anybody with an answer?
No.
Ebu ask
Yes.
the question again, please.
Is the patient malnourished?
The patient is not malnourished.
Okay. The patient is not malnourished.
Oh, sorry. Uh-huh. I'm looking at the BMI is 21. We don't use BMI to say that the client is malnourished. It's not about the low weight or high weight. We have to look at what they are missing, especially in terms of nutrients, for us to use the word malnourishment.
Exactly. So that's a good one. Now, nyinyi mmesema no na yes. Okay, so some people say yes, some say no. Okay, so let's see what the answer is. So according to the GLIM criteria, GLIM is basically for global something of malnutrition, EOLI, I'll tell you. And remember, yesterday we also learned some things about malnutrition classification, about phenotypic and etiological. But let's look at this. For the diagnosis of malnutrition, the patient present one phenotypic criteria: unintentional weight loss more than 5% within past 6 months. Bani, si tulisoma hiyo jana kwa phenotypic. Yes. Yeah. So, and one etiological criteria, any reduction of food intake for more than 2 weeks, therefore the diagnosis of malnutrition is confirmed irrespective of BMI. Nyinyi wenye mulisema no, must withdraw answers zenu. So guys, what are we trying to say here? If you only rely on BMI to classify whether a patient is malnourished or not, you'll get it wrong. And this is the mistake we've been doing. You find many patients either admitted in our wards with a normal BMI, or patients we are managing in our clinics just with the normal BMI. Without us doing a better history taking, we might miss it. So yesterday I brought in a certain important narrative. We have what we call phenotypic classification and etiological classification. If you are not there, please get time to listen to that recording. I'll also be able to share the notes so that you just have a look at them. So this patient has lost more than has lost weight in the past 6 months, and that is a classification. And of course, they have etiological and phenotypical. So they have met the criteria. So indeed, our patient is malnourished. Oh, unfortunately, answer 2 mshaangalia. Anyway, msijali. To grade the severity of malnutrition, it is necessary to measure muscle mass function. I know, Banis, you know this. Therefore, muscle quantity or muscle strength should be assessed, for example, by bioimpedance analysis or by hand grip test. So again, that is something also you need to check. If they are weak to press the hand grip, then you know that they have muscle weakness. Anyway, question 2, I've already given you an answer there. It's asking which nutritional intervention is indicated. So enteral nutrition by nasogastric placement is indicated. Since endoscope could be performed, positioning an nasogastric tube for feeding and hydration is likely to be possible. Then after nasogastric tube placement, confirmation of correct positioning by chest X-ray. pH remember yesterday we also discussed pH testing having been equivocally probable because the patient is on proton pump inhibitor. Remember, Our patient has esophageal cancer. So most patients with esophageal cancer usually put on proton pump inhibitor like omeprazole because they usually have gastroesophageal reflux or hyperacidity. So you need to do the pH. Remember, pH we said it should be less than 4 yesterday. And then, of course, hydration and continuous enteral nutrition by pump administration was started while waiting for the results of further histology. So the endoscopy, we can in place nasogastric tube during the endoscopy performance. And of course, we wait for histology. Then one day after starting enteral nutrition, the patient complained of sudden and severe shortness of breath, pink and foamy mucus. So that is just a continuation of the information we have. So which is the most likely diagnosis for these patients? The likely. So just to continue because of time, so the refeeding syndrome causing acute heart failure should be considered in differential diagnosis. Remember, if we go back to our case, our patient was admitted, presented to the emergency room with 4-week history of progressive dysphagia. He has a history of alcohol abuse and of esophageal cancer treated with combined radiation. Remember, chemotherapy, we also said could be one of the issues to look into for refeeding syndrome because of that. Then 2 weeks before presentation, he has started to have reduced oral intake, and by 5 days prior to admission, he has completely stopped eating. So this is a patient who has not been eating for the last 5 days. And you remember here, allow me to go back, little or no nutrition intake for more than 5 days, this patient is already at risk of refeeding syndrome. History of alcohol abuse, drug, insulin, chemotherapy, refeeding syndrome. Si tuko sawa hapo? Is it making sense? Nutrition is so sweet sometimes. So you just need to take time, read case, play with numbers here and there, so you'll be able to really learn a lot. Okay, so yeah, so refeeding syndrome is one of the things that you expect this patient to have. So dysphagia of any etiology significantly impairing food intake for many days increases the risk of refeeding syndrome. It may develop also in patients who are not extremely malnourished in the presence of significant weight loss. And of course, according to British NICE criteria, the patient is at risk of refeeding syndrome through presenting 2 criteria. 1, little or no intake for more than 5 days, and history of alcohol abuse, stroke, chemotherapy. So our patient is really a typical patient to have a refeeding syndrome. Most likely they'll have a refeeding syndrome. So continuation of our case study, almost the last slide. Chest radiography indicated pulmonary edema and pulmonary embolism, was excluded by CT pulmonary angiograph. So these are just tests that were done. The patient was treated with diuretics because of the pulmonary edema. Tube feeding was temporarily ceased. Serum electrolytes, potassium, phosphorus, and magnesium were checked and corrected as needed. Which is the best nutritional and therapeutic scheme when resuming enteral nutrition? So remember, we had started enteral nutrition, but we temporarily stopped it because of the issues of pulmonary edema and pulmonary embolism. So which is the best nutritional and therapeutic scheme when resuming enteral? So 1, thiamine supplementation should be provided with refeeding. IV fluid should be limited or avoided. So we need to give thiamine for that. Remember, we are looked at thiamine. Then IV fluid should be limited or avoided because already we have pulmonary edema. So please stop IV fluids. Enteral tube feeding should be resumed at 10 to 15 kcal per kg per day and increase slowly over time, aiming to meet a target calorie requirement within 1 week, but no sooner. So remember, if I go back to another slide, we said, yeah, here, we said nutrition support, we can start at 10 to 15 kcal per day. Then we increase it during the first week because already this patient is at risk of refeeding syndrome. So that is the explanation. Then monitoring clinical and laboratory parameters. So you need to cardiovascular, neurological, nutritional status, and plasma electrolytes, and adequate vitamin supplementation during treatment is essential. So this is a patient who will qualify for multivitamin supplementation. Then enteral nutrition was resumed successfully in the patient. And after 7 days, he was scheduled for discharge. His weight was 65.5 kg. So let's go back to the original weight, was around 65. So at least we've gained 0.5 kg. So this is after 7 days. So meaning we are within what we had said, 0.5 per kg is okay. Respiratory function was normal. Enteral nutrition well tolerated, and there were no signs of fluid retention. So plasma electrolytes were normal, albumin 35 grams per liter. Biopsy show local relapse of tumor with no signs of distant mets on CT scanning. The patient was listed for esophageal stent implantation and further chemotherapy, which is the best long-term plan for this patient. So basically, this question is asking you which tube feeding is okay. So remember, we looked at the long-term feeding. So the long-term plan should include evaluation of response to nutrition therapy based on clinical, nutrition, and laboratory parameters, and adjustment of therapeutic prescription based on results of monitoring assessment. So basically, these are patients whom you can recommend tube feed, like gastrostomy tube. Maintenance, recovery of body weight, and composition are essential in this case to avoid complications related to oncological treatment and to maintain good functional status. So the long-term plan here, you need really to consider the issues of gastrostomy tube because we are going to have esophageal stent. So long-term, you need to have G-tube so that you'll allow the esophagus to heal. So that is about the case study for today. And that is the end of my presentation on that issue. Any question?
Hello, Mr.
How was?
Okindo.
Hello.
I have a question. First of all, that was a very nice presentation. Then my question is, the weight that I'm going to calculate the total kilocalories or the nutrient requirement of the patient, is it the 65 kgs or the 71 kgs?
No, the 65.
Yeah.
Remember we are doing 10 to 15 kcal as a slow. So just start at 65, the current weight. Then once now we already we call it a catch-up phase. The patient is out of refeeding syndrome. Then now you can now start. Of course, we usually advocate that if you are able to give the feeds continually, then you are able to meet the catch-up, the weight you are targeting. Remember, reaching 71 will take a long time, but just start at the current weight the patient has. Don't look at the ideal weight that they are supposed to have. So just start with the current one.
Thank you.
After the refeeding syndrome has been sorted out, then now you can be able to really go to the catch-up weight. All right. Any other question?
I have a question.
Yes, go ahead, Nguka.
On supplementing, especially the electrolytes, the phos, the mag, and the K, there is the new clinical and dietetics manual where they recommended that we do the supplementation regardless of the lab, and then we continue monitoring as we continue feeding. It's something that we do practice in our pediatrics, but in the adult, we really don't do it. What's your thought on that?
Yes. I'll totally agree with them that we do supplementation regardless of the lab works, because again, most of the patient, many a times the patient we are admitting or we are facing during the first time of contact, they are already in the refeeding syndrome state. So whether you've done the lab works to confirm that they are okay, please just go ahead and do the supplementation. So don't really hold on to it. Continue doing the supplementation. And then the good thing is if you're doing multivitamin, you are not at risk of any elevation. It's really rare to have it because some of it will also be lost through the gastrointestinal tract. Okay, so allow me just to go quick to your questions. So Marisha, you have what osmolarity causes diarrhea and which products have the high osmolarity? Of course, so osmolarity, we are just looking at the in terms of the kilocalorie content. So for example, you find some feeds which has a higher kilocalorie. Those might have if you start with a higher volume, high kilocalorie, then like for example, protein energy, high, what I call Fresubin to Kcal, for instance, they have a higher osmolar, meaning that they have a higher higher kilocalorie. So such product might in a way cause issues to do with diarrhea if you start them at a higher rate. So you need to start slow. Maybe you can do 1.5 kcal per ml. Then, of course, as you transit, you increase the amount. But allow me just to quickly, I'm seeing time is really going on. I'll do the last one. Okay, here we go. So we have different tube feeding. This slide, this one, I might not go through all of it, but I'll be able to share. So in case you want to prescribe the nutritional product, we have to really be sure to have this. So I'll have this so that these are a nutritional formulary with supplements. So I know many of you know these supplements by their brand names, but there is a way they are classified. For example, nutritionally complete liquid diet, normal calorie for tube feeding, providing 1 kcal per ml, 3 up to 2 liters. So definitely this will if you go and check different brands, you'll know which one falls under that. They have indications, contraindications. So we have quite a lot. I'll just share this for your reference. You can use it in your facility, print it, and have it as your nutritional formulary. We even have special formulas, and then this can be able to assist you in knowing which product you're looking for. So even if you are calling the brands, you can call them when you already have this one, because usually when we are doing prescription, we don't recommend branding. Like you can't prescribe something like Fresubin to Kcal unless you have what we call a contract with that company, unless they are paying you. So please don't use brand. But again, because we rarely don't have this formulary, that's why you find many people prefer to use brand than. And again, if even you call the product, they usually tell you the brand name. So, then can aspiration from enteral feed cause sudden death? Yes. Charlene, aspiration can cause sudden death. If we can have lung collapse, that can cause sudden death. So it's a big thing. That's why when patients are going to theater, they're usually sedated to avoid aspiration. And we are saying we starve them so that the food should not be in the system. How is fiber introduced in the blended food? So several ways. I was trying to avoid this blended food, but let me come in. So if you want to introduce it, of course, you need to look at soluble fruits, soluble fiber. So mostly from fruits. So those fruits that you'll blend with the outer cover, they are the ones that they can assist you in that. So I think vegetables and fruits are soluble fiber. So you can introduce them into the diet of a patient if you are doing a blended food. What's the best way of increasing sodium that you use naturally without medication and the patient has hypertension? Wow. Banis, here, this one I might not be able to answer today unless I found out. I don't have the real answer on how we can do that. But because the recommended if a patient is hypertensive, we use 1,500 milligrams of sodium per day. So that is like a teaspoon, then you levelize. I think it will give you use that for a whole day. So I need to look at the best way of doing that. We give vitamins. Does it multivitamin? Yeah, of course, multivitamin will able to sort you out. Sometimes we usually have multivitamin injection. I am just forgetting the name. Pabrimex. It's called Pabrimex. Yeah. So especially patients who have had what is it called? Who have had alcohol withdrawal syndrome, the Wernicke-Korsakoff, then you can give them Pabrimex. Yes. So with that said and done, unless we have a question, we can call this class a success.
Just a minute.
Yes, go ahead, Marisha.
You said on using soluble fiber, we are blending these foods. Does the mechanical breakdown affect the fiber content? Because we give that, but the patients are still constipated, even if they're not on the opioids like morphine.
Not really. Mechanical breakdown will not change the fiber content. The fiber will still be intact. It's just like we are modifying it. So comparing that, let's say, for example, we are using a blended, we've blended apple, which is a soluble fiber. You'll still get the same nutrients that you are getting, unless you sieve and you are able to get them out. But if you blend to the better part and you have a larger diameter enteral feed, it will not affect. Most of the time, it will not affect. So if the constipation continues, for instance, you remember we learned that you can even give lactulose for that patient to assist them. But again, we need also to investigate other things. But it rarely will it have an impact again. I don't think we are going to have any changes in the fiber. Maybe if somebody has a different opinion or anything, you can let me know. But I don't think we can experience issues with fiber. I don't think so. But we can usually I can find out. But we rarely have those ones. All right. So I've seen time is gone. This class is supposed to have like 1 hour 30 minutes. We are 6 minutes off. So I want to say thank you very, very much. And I hope this class has been very impactful to you. Maybe you give me a comment. How was it? Has it helped you? One thing I promise I'm going to do is how to calculate the enteral feeds and even rate. If I do that and I help you on that, you are going to be the best nutritionists and dietitians that the hospital has never seen. If you go step by step how to do those calculations, you'll be the best people have never seen, and people will always look for you if I help you on that. Thank you very much. I think we end it there. So if we have any comments, feedback, kindly let me know. I hope learning has taken place. So the recording and presentation will be ready. You'll be able to have the review later on. I'll also share the slides, so don't worry. I'll also share the slides. And thank you very much. So we end it there. Conversation continues in the WhatsApp group. If we have any case, please post it there. We'll be able to tackle it so well. We'll be able to guide you which enteral feeds to give. If it is parenteral, we'll be able to do it. I'm working to form one WhatsApp group for us so that because I've seen most of us have been people who continually we have this series. So we can be in one WhatsApp group. So if we have another training, we just share in the group. We can also look for it to build us up. I'll also be working on certificate. If you give me like 1 to 2 weeks, because I need to process quite a number, I'll be able to do that and share to each and everybody's WhatsApp via WhatsApp, if that is okay. All right. Thank you. Have a lovely evening. Let's continue the conversation in the WhatsApp group. Thank you very much.
Thank you. Good night.
Good night.